Hello everyone, I am Dr. Priyanka Sachdev here, NEET PG educator on Unacademy. So I have started a series on diabetes mellitus in which we have already understood the pathology portion of the diabetes, that is the classification and the pathogenesis of various types of diabetes, and also the clinical features, complications, diagnosis, everything about the diabetes mellitus. Now coming on the pharmacology portion. So today I am going to teach you the treatment of diabetes mellitus. So in this lecture, I will teach you everything about the insulin preparations available in the market and oral hypoglycemic drugs available in the market, the mechanism of action, the adverse effects, so everything about them. So basically, I'm going to teach you the treatment of diabetes mellitus in this lecture, and it is going to be very useful lecture for all of you. So it is a pharmacology lecture, right? So before that, for the students who have missed the initial lectures or initial recordings, I would like to give you an overview for the 5 or 10 minutes that what is diabetes, and if you don't understand the basic mechanism, that the pathogenesis of type 1 and type 2 diabetes, you can't understand the mechanism of action of the various types of oral hypoglycemic agents and insulin. So let me give you an overview in the first 5 minutes, and then I will come on my chapter very soon. So we know that human has an intra-abdominal organ, that is pancreas. Can you see a pancreas? It is an intra-abdominal organ. Now, although anatomically it is a single organ, but histologically and functionally, pancreas is a dual organ. It is having an exocrine part as well as endocrine part, right? So, pancreas is having two parts, exocrine as well as endocrine. Can you see here? Exocrine parts secrete enzymes which are helpful in digestion. Endocrine parts secrete hormones which are useful for maintaining blood glucose level. You can see this is the same pancreas which I have shown you in the last diagram, and this is the histology of the pancreas, right? In this histology, can you see this is the exocrine part in the form of the various ducts. These ducts are known as acini, but currently I am not interested in the exocrine part. Exocrine parts secrete enzymes, and it is in the form of various ducts. You can see the circular ducts, and these ducts are known as acini. So I'm not interested in this part today, right? The second part is the endocrine part. This is the endocrine part. It is known as Islet of Langerhans. It is a collection of cells. Can you see this is a collection of multiple cells? It secretes hormones. It secretes hormones. Now there are four types of cells which secrete four different type of hormones in the endocrine part. What are the four different endocrine part? Have a collection of cells. The collection of cells is known as Islet of Langerhans. It is having basically four major cells. The four major cells are alpha cell, beta cell, delta cell, and pancreatic polypeptide cell. So alpha cell secrete glucagon, beta cell secrete insulin, delta cell secretes somatostatin, and pancreatic polypeptide cells secrete pancreatic polypeptide. Have you got it? So there are four types of cells secreting four different types of hormones. That's it, right? That is about the endocrine part. So you have understood about the anatomy of the pancreas, the two types of the histological or functionality of the pancreas, and exocrine part, endocrine part. And in the endocrine part, we have understood the various types of the cells which are important. So today we will talk about the insulin, right? Okay. So let me come on diabetes. So I have already taught this in the last lecture that what is diabetes? What is the problem in diabetes? So any type of diabetes, you talk about type 1 diabetes, type 2 diabetes, various types of MODIs, gestational diabetes, genetic diabetes, any diabetes. All diabetes have one common feature. What is the common feature in all type of diabetes? It is hyperglycemia. What do you mean by hyper? Hyper means more. And what do you mean by glycemia? Glycemia means blood glucose level. Blood glucose level. Have you got it? So the person with diabetes have high blood glucose level. Now whether it is type 1 diabetes, type 2 diabetes, whatever diabetes, all the diabetes have one common feature, that is the person have high blood glucose level in the blood. That is about diabetes. So when blood glucose level become too high, the person is diagnosed as diabetes. Now who regulates the blood glucose level? Now in this diagram, the beautiful sketch diagram in front of you, you can see there is a blood compartment of human being and there is a cell. There is a cell. Now a homeostasis is maintained between the blood and the cell for blood glucose level. Now there are two hormones which come in role, insulin and glucagon. You can see clearly in the diagram. Now there is insulin, there is glucagon. Insulin is secreted by beta cell of the pancreas, as I have already told you. Glucagon is secreted by alpha cell of the pancreas, as I have told you, right? Now these two hormones are present in the blood, right? Now you can see the arrow. What insulin is doing? Insulin is shifting the glucose from the blood to the cell and storing the glucose in the cell in the form of the glycogen. So basically insulin is decreasing blood glucose level, right? Glucagon is doing just reverse. It is shifting the cell glucose level from the cell to the blood. It is causing degradation of the glycogen and shifting the glucose from the cell to the blood. So it is basically increasing blood glucose level, and we require both. How we require both? How we require both? How? So just imagine a situation. I'm having my breakfast. So immediately after breakfast or lunch or dinner, after any meal, what will happen? The food will go in my GIT, it will go in my mouth, it will go in my esophagus, it will go in my stomach and intestine. So after going in my GIT, the glucose or the carbohydrate content of the food will be absorbed and go in the blood, right? So the blood glucose level will rise immediately after the meal. At that time, insulin will come in the role, right? Insulin will shift the glucose present in the blood to the cell and decrease the blood glucose level and do it normalize. So what is the normal blood glucose level? If you talk about fasting level, it is 80 to 100, 80 to 100 milligram per deciliter. And if you talk about postprandial, it is less than 140 milligram per deciliter. So that is postprandial. So you have to learn these two levels thoroughly, right? Now imagine a situation, a person is fasting. A person is fasting, the food is not available, or the person is busy, or due to some religious situation, the person is doing the fasting. So fasting means person is not eating anything. At that time, the blood glucose level gradually start falling, but body cannot afford that. Body cannot afford blood glucose level less than 80, because brain has to get constant supply of the glucose. At that time, glucagon will come in the role, and glucagon will shift the stored form of the glucose from the cell into the blood and again maintain the normal blood glucose level. So these two hormones, insulin and glucagon, will play their roles during meal and during fasting state, and they always keep the blood glucose level in constant level. Have you got it? So during meal, insulin come in role, and during fasting state, glucagon come in the role, and both of them together maintain a homeostasis of blood glucose level in the human body. Have you got it? So this is normal. This is normal. But what is the problem in diabetes? Let's talk about the diabetes. What is the problem in diabetic patient? What is the problem? Yes, what is the problem? The problem in the diabetic patient is with insulin. Can you see? The insulin is either, I have make a cross. What do you mean by that cross? Either the insulin is absent, or if it is present, it is non-functional. So can I say it is absent means it is a quantitative defect, and if it is present but non-functional, it is a qualitative defect. So either the defect is quantitative or the defect is qualitative. Have you got it? So insulin is either absent, or if present, it is non-functional. So in this situation, what will happen? This arrow is non-functional. So the body cannot shift the glucose from the blood to the cell. But reverse can take place because glucagon is functional, but insulin is non-functional. Now you yourself tell me what will be the two consequences of this. What will be the two problems? If blood glucose level is not shifted into the cell, blood glucose level will rise tremendously and cell glucose level will fall tremendously. Both will happen. Both will happen because glucose is not shifting from the blood to the cell. इंसुलिन इज एब्सेंट और नॉन फंक्शनल, सो ब्लड का ग्लूकोज सेल में नहीं जा रहा, तो ब्लड में बढ़ जाएगा, सेल में कम हो जाएगा. ब्लड ग्लूकोज लेवल विल राइज ट्रेमेंडसली एंड सेल ग्लूकोज लेवल विल फॉल abruptly. Have you got it? Have you got it? Now what is the problem? Symptomatically, what is the problem to the patient? Now imagine I am the patient. If my blood glucose level is 80 or 100 or 150 or 200 or 500, how does it matter to me? I don't check my blood glucose level every day, but does it causing any problem to me? Does it causing any trouble to me? Does it causing any symptoms to me? Yes. So if blood glucose level is raised constantly for many years, it will cause damage to basically three organs of the body. It causes damage to all organs, but basically three organs are more susceptible: the kidneys, the retina of the eye, and nerves coming from the brain, the peripheral nerves, right? So diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy are the three complications of raised blood glucose level in the blood for years. These are the three chronic complications of diabetes, you can say. That's why we have to give the treatment. That is my lecture today. So I will give treatment to my patient to reduce the blood glucose level and do it normal. Do it normal. Don't keep the blood glucose level too high for many years. Otherwise, three organ will be permanently damaged. We cannot reverse it. It is the irreversible loss. So diabetic nephropathy, retinopathy, neuropathy, once happened, you cannot reverse it. The organ damage is permanent and organ damage is there because of high blood glucose level, right? In the last lecture, I have explained you how this high blood glucose level is doing this damage by three mechanisms. So those who have missed the recording, I request them, please watch the recording. Please, right? Now, what is the problem if cell is having less glucose? Does the cell have any problem? Yes. It means cell have less glucose. Cell cannot synthesize ATP. For synthesizing ATP, cell require glucose. So it means the cell is doing starvation. The cell is starving. The cell is starving. Have you got it? Despite of having abundant of glucose right at the doorstep, the cell is starving. Right? Have you heard a proverb? Diya tale andhera, samundar tale pyasa. The same situation is happening with the cell. The cell is floating in blood. This cell is floating in blood. The blood is having abundant of glucose. But the irony is that this cell cannot utilize that glucose. Right? So pity on the cell. Have you got it? So the cells are starving despite of having abundant glucose, because for shifting glucose from the blood to the cell, we require insulin. We require functional insulin. So here either insulin is absent or it is non-functional. Have you got it? Have you got it? So that is the thing. So that is the defect. Either the insulin is absent or there is a defect in insulin action, or both of the above, right? Now, before coming on the artificial insulin preparations available in the market, I would like to revise you the natural insulin. How natural insulin is synthesized in human body, in my body, your body, all human beings body, how it is released and how it is doing its action, the mechanism of action of the insulin. So I would like to revise you these three topics, and then we will go ahead. So insulin synthesis, insulin release, and insulin action. How insulin is synthesized? Of course, it is synthesized inside pancreas. We have already seen it. So inside pancreas, is it synthesized in the exocrine part or endocrine part? It is synthesized in endocrine part. So endocrine part is islet of Langerhans. So in islet of Langerhans, we have four cells: alpha, beta, delta, and alpha, beta, delta, and pancreatic polypeptide. So it is synthesized in beta cell. So let me zoom. Can you see this is a beta cell? Okay, this is a beta cell. Let me zoom this cell. Let me zoom this cell and see how insulin is synthesized inside it. So this is a beta cell of the pancreas. Imagine this is a beta cell of the pancreas. Now see how insulin is synthesized inside them. Now, okay, let me draw it. You have to understand it to understand the artificial preparations of the insulin. This is a beta cell of the pancreas. Like all cells, it also have a nucleus. Like all cells, the nucleus have chromosomes. So these are the chromosomes or DNA present inside the nucleus. On the chromosome, we have a gene which is known as insulin gene. This gene is insulin gene. Now, insulin gene say with the help of transcription and translation, a protein is formed. So with the help of transcription and translation, first with transcription, mRNA is formed. Then mRNA will come out, and on ribosome, mRNA will convert into protein. So this protein which is formed from the insulin gene is known as pre-proinsulin. First a pre-proinsulin is formed. Then it convert into proinsulin, and then it convert into insulin. Have you got it? So first protein which is formed is pre-proinsulin, which convert into proinsulin, which convert into insulin. What do you mean by pro, and pro? What is the difference between them? Okay, here is the difference. You can see the beta cell. Of course, you can see. In this beta cell, can you see the pre-proinsulin? It is synthesized from insulin gene. Insulin gene यहाँ नहीं दिखाया इस diagram में. But you can imagine इस cell के nucleus में insulin gene से बना है pre-proinsulin with the help of transcription translation. Pre-proinsulin में four chains हैं. One is alpha chain, the red color. One is beta chain, the blue color. One is C peptide, C for connecting alpha and beta. Can you see the C peptide is connecting alpha and beta, the green color. And the fourth one is signal peptide, the yellow color, which is present on the amino terminal of this chain, on the beta chain, right? That is pre-proinsulin में चार चीजें हैं: alpha, beta, connecting peptide, and signal peptide. Now signal peptide is removed by proteolysis. It is removed in endoplasmic reticulum. It is removed. Now pre-proinsulin get converted into proinsulin. Proinsulin have only three chains: alpha chain, beta chain, and connecting peptide, the C peptide, that is proinsulin. Again, the C peptide is separated. Now there is proteolysis of this C peptide, and only two chains are remaining: alpha and beta. That is insulin. So in insulin, basically we have two chains: alpha chain, beta chain. Now please don't get confused. This all thing is happening inside a cell of the pancreas, which is known as beta cell. सेल का नाम है बीटा सेल, उसके अंदर इंसुलिन बन रहा है. इंसुलिन में दो चेन है, अल्फा चेन एंड बीटा चेन, राइट? अल्फा चेन is having 21 amino acids. Beta chain is having 30 amino acids, and combined both of them have 51 amino acids. So you know that, right? So you have to learn that. Now insulin discovery got a Nobel Prize. You already know that, right? So there are 51 amino acids in the structure of human insulin. Alpha chain 21 amino acid and beta chain 30 amino acid. And a connecting peptide is separated, which is of 35 amino acid. It is separated. So whenever, let me draw a blood vessel. This is the blood vessel. Whenever one molecule of insulin come in the blood, With the one molecule of insulin, one molecule of C-peptide also come in the blood. It is complementary. It always happen together. So along with one molecule of insulin, one molecule of C-peptide also come in the blood at the same time. So if you check the blood level of a person, the molecules, the amount of C-peptide is exactly same as that of amount of endogenous synthesized insulin. So can I say that this C-peptide is acting as a surrogate marker for endogenous synthesized insulin? Okay, just suppose this patient is having diabetes. Let me draw a person for you. This is a person. He is having diabetes. The diabetes either type 1 or type 2 not controlled on oral hypoglycemic agents. So for treating this person, I am giving artificial insulin. I am giving artificial preparation of the insulin for the treatment. And this is the natural insulin. Natural is not zero. It is present but in small amount, right? So natural is not zero. Now I am taking the blood sample of this person in a test tube, right? I want to see what is the reserve, what is the natural insulin, so that I can decide the dose of the artificial insulin, right? So how I will check? The body contains both natural and artificial, and the structure of both of them is exactly same. You cannot distinguish the exogenous and endogenous insulin. Structure wise, they are exactly same, right? So check the level of C-peptide. Check the level of C-peptide. Whatever amount of C-peptide is present, it is equivalent to endogenous insulin, not exogenous. So here comes the role of C-peptide. C-peptide gives us a surrogate marker of endogenous synthesized insulin, or the insulin reserve, the pancreatic beta cell reserve, you can say, right? So please, there is a relevance. So you can see this is the final diagram of the insulin. Okay, I will show you. See this diagram, this one. It is pre-pro insulin. So it is having 4 chains. Can you see? Alpha, beta, connecting between them is the C-peptide, this one, the green one, and the amino terminal, the yellow one. Now the amino terminal is removed. Can you see? It is removed. In the endoplasmic reticulum, it is removed. Now we are having only 3 chains, alpha, beta, and a connecting peptide between them, the C-peptide between them. So this is known as proinsulin. Now pre-proinsulin get converted into proinsulin. Now the C-peptide is also separated. Having 31 amino acid, it is separated, and only alpha and beta are remaining. Alpha having 21 and beta having 30, total 51 amino acids. You can see it is insulin. Please learn it. So this is the best diagram I can show you. The same diagram from the KDT you can see. Okay. Let me show you alpha and beta chain. Okay. Alpha chain. This is A. A chain is alpha chain. Starting from 1 amino acid to 21 amino acid. Can you see? This is 21. Amino acid number 1 to amino acid number 21. Now there is a connecting peptide between them. This is C peptide, connecting peptide. It is the diagram of proinsulin, not insulin. And see the beta chain. This is the beta chain. I will show you the beta chain. This one. In the beta chain, this is amino acid number 1. This is number 30. So total alpha plus beta, 51 amino acids are there. This is proinsulin. Now comes the role here. Now we synthesize insulin from human. Nowadays we use only human insulin. But before this era, we use pork. Pork means pig. Pig insulin or beef. Beef means, beef means cow. Cow or buffalo. Beef insulin, right? So we use pork or beef insulin. Now pork or beef insulin also have 51 amino acids like human insulin only. So alpha beta chain, they also have alpha and beta chain. Alpha chain of all of them have 21 amino acid, and beta chain of all of them have 30 amino acid. So you will say, ma'am, then what is the difference? There are 2 differences on alpha chain and 1 difference in beta chain. So let's talk about alpha chain and beta chain. What is the difference between pork and beef insulin from human? पे बहुत MCQ आते हैं. Please learn this slide. Please everyone, I request you. Let me teach you pork insulin. On the pork insulin, the alpha chain का 8th amino acid is threonine. It is exactly same as that of human. अल्फा चेन का 10th अमीनो एसिड इज ऑल्सो सेम. सो पॉर्क में सिर्फ एक ही डिफरेंस है बीटा चेन में. बीटा चेन का 30th अमीनो एसिड, द लास्ट अमीनो एसिड, ह्यूमंस में थ्रियोनिन है बट पॉर्क में एलेनाइन है. So only beta chain का last amino acid, 30th amino acid is different. In human, the 30th amino acid of beta chain is threonine, but in pork it is alanine. But alpha chain is exactly same. Exactly same. There is no change in alpha chain. Right? Let's talk about beef. Beef insulin. Let's talk about beef insulin, the cow insulin or beef insulin. Beef insulin have 3 changes. Number 1, alpha chain mein humans have threonine at the 8th amino acid, beef have alanine. At 10th amino acid, humans have isoleucine, the beef has valine. At beta chain at 30th amino acid, humans have threonine, the beef has alanine. So there are 3 differences. So pig is only different in 1 amino acid, cow is different in 3 amino acid. So which is more close to human insulin? The pork or the beef? The answer is in front of you. Yeah, MCQ multiple times it is repeated in your exam. Which insulin is more close to humans? So answer is pig. Pig is more close to humans, as the pig means, I mean pork. The pork is more close to the humans as compared to beef. Because pork differ only in one amino acid out of the 51, but beef differs in 3 amino acids out of the 51, right? So it is more allergic. The beef is more allergic as compared to pork is also allergic because one amino acid is different, but not too much. So it is more similar or more close. So we want a artificial insulin which is more close to the human. But nowadays not pork nor neither pork nor beef is used. Nowadays we synthesize human insulin only by genetic technology, right? Genetic engineering. So that's it. You have to learn the slide. You can't imagine any MCQ can come on this slide. So you have to learn the number of the amino acid and which amino acid is replaced by which amino acid in pork and beef. So to learn the slide is your job. I have given all the information, right? So this is the summary. The beef insulin is differed from human insulin by 3 amino acid, and the pork insulin differs from human insulin by 1 amino acid. So which is more close? Of course, pork is more close to human as compared to beef. And which amino acids are different? It is only in beta chain. It is 2 in alpha chain and 1 is beta chain. Total 3 are different. Learn what is the difference. Which amino acid in human is replaced by which amino acid in pork and beef respectively. You have to learn that. Okay. So we are done with insulin synthesis. Normal natural insulin synthesis. Let me teach you insulin release and action also. Then I will come on oral hypoglycemic agents and artificial insulin preparations. How insulin is released in human body normally? I'm talking about normally. I'm talking about my body, the normal human body. How insulin released in blood? It is present in the pancreas. Now I am a human body. Inside me, intra-abdominal organ pancreas is present. In my pancreas, I am having islet of Langerhans. In my islet of Langerhans, inside my pancreas, I am having 4 cells: alpha, beta, delta, pancreatic polypeptide. My beta cells, inside my beta cells, insulin is already present. It is synthesized, it is present in granules. But when this insulin will come in my blood? It is not coming in blood always. When it will come? What is the trigger? What is the trigger for the insulin? Right? Okay. Let me come on insulin release. So can you see this diagram, the beautiful diagram, the master diagram in which I am going to teach you the mechanism of action of all oral hypoglycemic drugs. This is a master diagram. Please understand it. Okay. Okay, so can you see this is a meal. A person is taking, just suppose I'm taking a meal. My meal, I mean the 3 big meals: breakfast, lunch, or dinner. I'm either taking breakfast or lunch or dinner. So the glucose in the meal is going inside my GIT, in my esophagus, stomach, and intestine, and glucose is absorbed. After absorbing, the glucose will reach the blood vessel. Can you see? After reaching the blood, when the blood glucose level rises more than 70, normally my blood glucose level, if I'm not eating, it is less than 70. But if I have a meal, it will rise more than 70 because of absorption of glucose from the food into the blood vessel. So from the food, the glucose will move to the blood vessel and blood glucose level will rise more than 70. Give me a thumbs up if you got it. Now when blood glucose level rise more than 70, it will go to the pancreas. It will go to the pancreas and it will enter inside the pancreas. Inside the pancreas, this is a beta cell. Can you see? This is a beta cell. It will go to the beta cell. This glucose will enter inside the beta cell via a transporter. The name of the transporter is GLUT2. What is the name of the transporter? The name of the transporter is GLUT2. So this glucose will reach inside. After reaching inside, this glucose get converted into glucose 6 phosphate. And during this process, 1 ATP is released. Glucose got converted into glucose 6 phosphate and 1 ATP is released. The released ATP, there is another transporter present on the surface of the beta cell. It is potassium channel. It is ATP sensitive potassium channel. The ATP which is formed during this process will inhibit this transporter. So potassium channels are inhibited. No more potassium will come inside and the membrane will be depolarized. The membrane of the beta cell will be depolarized because of inhibition of this channel, right? Once the membrane is depolarized, there is third transporter present on the cell is calcium channel. The calcium channel will get stimulated. It will get open because of depolarization of the membrane and more calcium will go in. Influx of calcium will take place. Whenever calcium moves inside the beta cell, the insulin will come out. So this is the trigger. Now see the same beta cell. I'm zooming this portion. This is a beta cell. The diagram from the KDT. You have to understand this diagram, without which you can't understand the mechanism of action of oral hypoglycemic agents. You have to. You can't understand the mechanism of action sulfonyl ureas. You can't understand. That is the various glipizide, gliclazide. You cannot understand. So please understand this diagram. So this is a beta cell of the pancreas. Whenever glucose in the blood is more than 70 milligram per deciliter, it enters inside the beta cell of the pancreas via a transporter. The name of the transporter is GLUT2. After entering inside, glucose get converted into glucose 6-phosphate via enzyme. The name of the enzyme is glucokinase. While this conversion, one ATP is released. This ATP inhibit the ATP sensitive potassium channel present on the cell, beta cell of the pancreas. ATP sensitive potassium channels are damaged, right? They are inhibited. So this arrow is reversed. Normally potassium comes in. Now potassium is not coming in. Potassium is not coming in because that channel is inhibited. So the membrane of the beta cell will get depolarized because of this inhibition of the potassium channel. Now there is third transporter present on the cell membrane of the beta cell is calcium channel. It will get stimulated because of depolarization of the membrane. Once it gets stimulated, influx of calcium take place. Once the calcium come in, it will push the insulin to go out and insulin will come in the blood. Have you got it? So the same story is written in front of you. Glucose is the trigger. Glucose is the key regulator for insulin release. So who is causing insulin release? So glucose is causing. Whenever the person is taking meal, the glucose going in the blood, and that is the trigger. When blood glucose level are more than 70, it is entering inside the beta cell of the pancreas via transporter GLUT2. After entering, glucokinase is acting on the glucose, converting the glucose to glucose 6-phosphate. During this process, one ATP is released. This ATP inhibit ATP sensitive potassium channel. So no more potassium will come in. So membrane of the beta cell of the pancreas will get depolarized. So it will stimulate calcium channel. Calcium channel will open. Influx of calcium takes place and the intracellular calcium will push the insulin out. So this is how insulin secreted outside. Have you got it? So insulin is coming out. So the key regulator is glucose. Glucose is doing all these. So the same diagram from Robbins, the same diagram from KDT. Whatever you want to learn, this is the same diagram. Let me explain you this also. So where is the glucose in this diagram? I can't see GLUT2. Can you see GLUT2 in this diagram? Where is GLUT2? So glucose once enter inside it will get converted into glucose 6-phosphate, and once it get converted, it inhibit the potassium channel. This is the ATP sensitive potassium channel. ATP sensitive. ATP is inhibiting this channel. Once this channel is inhibited, the membrane will get depolarized, and because of depolarization of the membrane, calcium is coming in. Calcium once coming in, it will stimulate the insulin granules and insulin is going out. So the same diagram, same diagram. Now see in this diagram, the beautiful diagram, what information I have given. Can you see the blood vessel? Yes, you all can see the blood vessel of this person. Inside which, can you see the two colored dots, red and blue? The red is the glucose. Can you see the red is the glucose? First, glucose is coming from meal. The glucose is coming from the meal, and this glucose is going to the pancreas, knocking the beta cell of the pancreas, taking insulin out. So insulin is coming out, the blue one are the insulin. So the blue one are the insulin. Now glucose and insulin both are present in blood. First Glucose is coming, going to the pancreas and taking insulin out. Insulin is the best friend of the glucose. Now glucose, insulin both are present here. So that is insulin release. Now how it will act? How it will act, I will come on that also. Here for insulin release, one of the trigger is glucose. As I have told you, the glucose present in the meal, it is the trigger for insulin release from the pancreas. There are two more triggers. Two that you have to learn that also. So whenever a person have meal, the food go in the intestine. The food go first in the mouth, then esophagus, then stomach, then intestine. In intestine, from the intestinal cells, there are two more things come out from the intestinal cell in the blood. These are known as incretins. What are these incretins? The one is GIP, the second is GLP. What is the full form of GIP and GLP? GIP is glucose dependent insulinotropic polypeptide. Glucose dependent insulinotropic polypeptide, GIP. Glucose dependent insulinotropic polypeptide. The second is GLP, glucagon like peptide, right? These both will be secreted in the blood from the intestinal cells. Whenever meal will go in the blood, these will go in the blood. From the blood, they will directly go to the pancreas and cause the release of the, they will cause the release of the insulin. So following a food intake, the GIP and GLP come in the blood, and from the blood they will go to the beta cell of the pancreas. They will stimulate the beta cell and cause the insulin secretion. They will cause the insulin secretion, right? Both of them are destroyed by an enzyme. The name of the enzyme is DPP4. That is dipeptidyl peptidase 4, DDP4. Have you got it? So that is the thing. Can you see here? So whenever a person is taking a meal, whenever the meal is going in the intestine, these are the intestinal cells. From the intestinal cells, GIP and GLP both will come in the blood. From the blood, both will go to the pancreas, and directly from the pancreas, they will take the insulin out. So insulin के लिए total 3 triggers are there. Meal में the glucose present in the meal, and the GIP and GLP which are secreted from the intestinal cell. So 3 triggers: glucose, GIP and GLP. There are 3 triggers for insulin. For insulin, we have 3 triggers in human body, and these both are destroyed by a hormone that is DPP4, the name of the hormone. Now, imagine a diabetic person. You will tell me the answer. Imagine a person with diabetes. Okay, he is coming to your clinic. You have to offer some treatment to this patient. You have to offer some drug, artificial drug, that is oral hypoglycemic agent. So can you offer GIP analog or GLP analog? Yes, we can offer GIP and GLP agonist or analog, right? Because both of them in the form of the tablet, the artificial GIP agonist or artificial GLP agonist, because the tablet will also go inside, will be absorbed, and GLP will go to the pancreas and cause insulin secretion. In diabetes, the basic problem, the insulin is less. We want to increase insulin by any mechanism. So we can give artificially GIP and GLP analog. And GIP, GLP is destroyed by DDP. So we can give DDP antagonist also in the form of the treatment. DDP antagonist kya hoga? You are giving a tablet. The tablet contains DDP, DPP antagonist. So it will go inside, it will be absorbed, it will go in the blood. In the blood, it will destroy DDP. Once the DDP is destroyed, the natural GIP and GLP will not be degraded now, and they will act for a longer time. They will cause more insulin release in the blood. So in the treatment, 2 drugs I have already discussed: GIP, GLP analog, agonist, and DPP antagonist. That the details I will discuss later on when I will teach you all oral hypoglycemic agents. So you have understood insulin release के लिए there are 3 triggers. The first one is the glucose. You have understood the various receptors, what is GLUT2, what is potassium channel, ATP sensitive potassium channel, calcium channel. You understood the mechanism. The second and third is GIP and GLP. Both of them are destroyed by DPP4 enzyme. So you have to learn the insulin release ke 3 triggers. Now insulin action. Insulin is already in the blood. How it will act? How it will act? Insulin will act on 3 organs. What are the 3 organs on which insulin will act? Insulin can act on 3 organs. So can you see this is a molecule of insulin? It will act on 3 organs. The first is the liver. Can you see this is a liver? Yes. The second is a skeletal muscle. Can you see this is a skeletal muscle? And the third is the adipose tissue, the fat in the human body. The adipose tissue or the fat. These 3 organs have receptor for insulin. Can you see now human blood vessel have both glucose and insulin, right? So whenever the person is having a meal, in the meal glucose is present. So that glucose, the red dot is the glucose. It is absorbed and going inside. And from here GIP, GLP is also coming inside. So the glucose is also going to the pancreas. GIP, GLP is also going to the pancreas, taking insulin out. Ultimately, insulin is out. Insulin is present in the blood. It is out of the pancreas. Now blood contains both glucose and insulin. GIP, GLP are destroyed by the DPP. So ultimately, insulin is there. Now this insulin will go to the 3 organs. It will go to the liver, it will go to the skeletal muscle, it will go to the adipose tissue. On these 3 organs, there is receptor for the insulin. It will go and bind with its receptor. There is a tetrameric receptor for the insulin. Let me draw a cell. These 3 organs are known as target organs. If I say target organ, I mean the 3 organ: liver, skeletal muscle, and adipose tissue. This is a cell of target organ. It either is a cell of liver or skeletal muscle or adipose tissue, right? Now, can you see the cell membrane? This is the cell membrane. On the cell membrane, can you see a receptor? This is the tetrameric receptor. 2 alpha, 2 beta. This is a tetrameric receptor for the insulin. Okay. Can you see insulin is coming from the blood and binding with its receptor? It will bind with the alpha receptor and then it will stimulate the beta receptor. Once the beta receptor will be stimulated, a chain inside the cytoplasm will be stimulated. There is a various intermediates in the chain, IRS 1, 2, 3, 4, right? And ultimately, because of the stimulation of all these various cascade, various pathway, in the cytoplasm of these 3 target cell, in the cytoplasm, there is a transporter. The name of the transporter is GLUT4. GLUT4 is present in the cytoplasm inside vesicle. Can you see this is a vesicle inside which GLUT4 is present. Now, because of the stimulation of insulin to these intermediates, this GLUT4 from the cytoplasm, it will move to the cell membrane of these cells. So GLUT4 initially was not present on the cell membrane, but it come on the cell membrane because of the insulin stimulation of the this cell. So whenever insulin is coming to these three organs, the cell of these three organs, because of intermediates, various cascades, the GLUT4 present in the cytoplasm of these three organs, it will come on the cell membrane. It will be implanted on the cell membrane. It is known as trafficking and docking, right? So more and more GLUT4 is present on the cell membrane. That is the end result. You will say, ma'am, GLUT4 से क्या हो जाएगा? GLUT4 is the door entry for glucose. Now glucose can enter in these three cells because the door is implanted. Initially, if glucose want to enter into these three cells directly, glucose cannot enter. Let me show you just a second. In this diagram, you can see if glucose is present in the blood now. If glucose is directly going to these three cells, can I come inside you? Please take inside me inside you and store me. These organs will say, no, we don't have door for you. First implant a door, then you can come inside us. So what this glucose, now imagine I am taking a meal. This is my diagram, right? I am taking a meal. When I will take a meal, I will have my breakfast, lunch, dinner. The glucose present in the meal will go in my GIT. From the GIT, the glucose will be absorbed and go in the blood. From the blood, the glucose want to get stored in these three organs. So glucose is requesting the liver, skeletal muscle and adipose tissue, please take me inside you and store me. So they are saying, no, we cannot take you because we don't have door entry for you. First implant a door for you, then you can enter. So ye bichara glucose, this glucose is going to the pancreas and knocking the beta cell of the pancreas. The glucose has a friend inside the beta cell. The friend is insulin. So insulin is coming out. Glucose is taking the help of the insulin. Insulin is coming in the blood. After coming in the blood, insulin is saying, glucose, please wait. I am going to these three target organs. I will implant a door for you. Then you come behind me, right? So this is the best friend of the glucose, insulin. Insulin is going in these three organs. These three organs have a receptor for insulin, the tetrameric receptor, right? It will stimulate the tetrameric receptor. Because of stimulation of the tetrameric receptor, the various cascades IRS 1, 2, 3, 4, 5 get stimulated, because of which the door for the glucose, the name of the door is GLUT4. GLUT4, which is present in cytoplasm, it will move to the plasma membrane. Can you see the door is implanted? The door is implanted. The door is implanted. Now the glucose can come and do the entry in these three cells and get stored inside them. So inside liver, it will be stored as glycogen. Inside skeletal muscle also, it will be stored as protein or glycogen, or inside adipose tissue, it will be stored as fat, adipose tissue, right? So this is the storage form of the glucose. This is the whole story. Have you got it? Have you got it? So what is, so the same diagram is shown here also. Let me see what is actually happening. See the tetrameric receptor of insulin, two alpha receptors, two beta receptors. So can you see, this is the insulin coming from the blood, binding with the alpha receptor, stimulating beta receptor and stimulating IRS. IRS 1, 2, 3, 4, various cascades. Because of all these cascades, this is GLUT4. It is present in the cytoplasm. From the cytoplasm, it is moving to the cell membrane and getting implanted on the cell membrane. So that now the door for the glucose is implanted and glucose can do the entry in these cells. Now you like this diagram or this diagram, I have shown you all the diagrams from KDT also, Robbins also, other Katzunk also. So whatever the information is same, right? So that is the mechanism of action. So insulin receptor is a tetrameric receptor having two alpha units and two beta units present on target organs, right? So once it will bind with the alpha cell, alpha unit will stimulate the beta unit have tyrosine kinase activity. So stimulating the beta unit, first it will bind with alpha unit, it will stimulate beta unit will cause autophosphorylation of the receptor and stimulation of IRS, right? IRS 1, 2, 3, 4, 5, the PI3K MAP pathways will be activated. All these pathways will do the transportation of GLUT4 from the cell membrane, from the vesicle to the plasma membrane. So this is the door for the glucose. It is implanted on the plasma membrane. Now glucose can do the entry into these three target organs. I hope everyone got it. After entering inside these three target organs, glucose is stored in the form of the glycogen, protein, lipid. It is stored. Have you got it? So that is the summary. So glucose is stored in these three cells because of insulin. If glucose want to enter in these three cells directly, it cannot enter. So first insulin is coming, implanting a door for the glucose. The name of the door is GLUT4. GLUT4 is implanted in all of them, and now glucose can enter inside these cells with the help of GLUT4. It will enter and get stored inside these cells. So that is the ultimate summary if you got it, right? Give me a thumbs up, everyone. So I will start the drugs now. So I will start the chapter now. अभी तक तो पूरा तुम्हें revision चल रहा था और अभी तक तो पूरा overview. Now you will get it. Now you will get it. Right? So okay, just a second. Give me a minute. Sorry, I'm really sorry. Okay. 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 So let me teach you the revise you. We have already done the pathogenesis of type 1, type 2 diabetes. In short, let me revise and come on the artificial insulin preparation. We have two main type of diabetes, type 1 diabetes and type 2 diabetes. Let me start with type 1 diabetes. Type 1 diabetes. In type 1 diabetes, the problem is with the beta cell of the pancreas. Beta cell of the pancreas are destroyed. They are destroyed. So body cannot make insulin. Insulin is absent because beta cells are absent. So who is destroying the beta cell? Body's own immunity. Body's own immune cell, the T lymphocytes, the cytotoxic T lymphocytes, they become abnormal. Normally, these cells should kill the foreign cells. They should kill the foreign material, but they are killing the self cells. They become abnormal. So they become abnormal and they are killing body's own immunity. So can you see this is inside the pancreas? This is islet of Langerhans. Inside islet of Langerhans, this is a beta cell. So the T lymphocytes are coming and destroying all the beta cells, not alpha, not delta, not pancreatic polypeptide, not anything else. So it is destroying the beta cell. Since beta cell are destroyed, there is no insulin. No insulin means, can you see these are cytotoxic T cells? See the beautiful diagram I have drawn. These are cytotoxic T cells. They become self-reactive. They become abnormal. Normally, these self-reactive T lymphocytes are eliminated by the self-tolerance. Self-tolerance eliminate कर देता है. But body की capacity due to genetic abnormality, capacity loss हो जाए, so they cannot be destroyed. And these cells are destroying the beta cell of the pancreas. Since beta cell of the pancreas are destroyed, there is no insulin. Now, whenever this person have a meal, the glucose will go. ये person खाना तो नहीं छोड़ देगा ना, खाना तो खाएगा. So the glucose is going inside. The glucose is reaching the blood. So this glucose is going to the pancreas asking for help of insulin. But there is no beta cell. There is no beta cell, so insulin is absent. Technically, the insulin is absent in them. Since insulin is absent in them, if glucose want to enter these three target organs directly, glucose cannot enter because the door implantation is done by insulin and insulin is absent. So glucose will remain in the blood only. That is hyperglycemia. That is diabetes. That is the definition of type 1 diabetes. So that is the problem with type 1 diabetes. In type 1 diabetes, what is the problem? Due to genetic abnormality or environmental trigger, the T lymphocytes, they become self-reactive and they attack the beta cells of the pancreas because beta cell of the pancreas is autoantigen for them. So beta cells are killed, so there is no insulin, so increase glucose. Insulin कम है तो glucose ज़्यादा है. That is hyperglycemia, that is leading to type 1 diabetes. That is type 1. Let me come on type 2 diabetes now. Type 1 में the problem is in the pancreas कि beta cells are killed by self-reactive T lymphocytes. That is the problem. So insulin is absent in them. Absent. So quantity of the insulin is less. Either less or absent. That is the problem with type 1. Let's talk about type 2. What is the problem in type 2? In type 2, there is no problem with the pancreas. Pancreas is absolutely normal. Inside the pancreas, the beta cell is absolutely normal. You will say, ma'am, then what is the problem? You are saying pancreas is normal, beta cell is normal. So whenever this person have a meal, the glucose in the meal will go in the blood and it will go to the pancreas. It will knock the pancreas for stimulation of the, for secretion of the insulin. And if beta cell and pancreas is normal, insulin will come in the blood. I'm saying yes, insulin will come in the blood. Normal amount or rather increased amount of insulin will come in the blood. You will say, ma'am, then what is the problem? The problem here is with the target organs. These three target organs के ऊपर जो insulin का receptor है, the receptor for insulin on them is abnormal. The receptor for insulin on them is abnormal. Insulin is present in blood, but whenever it will bind with its tetrameric receptor, it cannot stimulate the receptor. The receptor is abnormal. Since the receptor cannot be stimulated, the receptor cannot be stimulated, the chain will not, the cascade will not be stimulated, the receptor cannot be stimulated, the cascade cannot be stimulated, and the GLUT4 present in the cytoplasm will not go on the plasma membrane getting implanted. So door for glucose is absent. So glucose will remain in blood only. The glucose cannot enter in these three cells because insulin is non-functional. So here the problem is that the insulin is non-functional. Non-functional. It is present, but it is non-functional. So the defect is qualitative defect. Here the problem is with target organ. Pancreas is normal. Have you got it? That is known as insulin resistance. That is failure of target organ. By target organ, I mean three organs: liver, skeletal muscle, and adipose tissue. These three are failed to respond to the insulin. Have you got it? That is the problem, right? Have you got it? Say yes or no. Have you got it? So, and insulin is rather more in them. Initially in them, the beta cells are normal, so they secrete normal insulin, so blood glucose is normal in them. But later on, the insulin receptors become abnormal. So insulin receptors are not responding to insulin. So blood glucose level is raising. To compensate it, so beta cell will do hypertrophy. Can you see compensatory beta cell? They are doing hypertrophy. They are secreting increased amount of insulin. And the insulin receptor is responding to increased amount of insulin. How should I explain you? Listen, I am saying when normal amount of insulin is coming here, the receptor is non-functional. But when increased amount of insulin is coming here, the receptor is responding to it. That is the thing. Have you got it? That is the resistance. So increased amount of insulin is overcoming the resistance, you can say. So for overcoming the resistance, body is synthesizing more and more insulin by doing beta cell hypertrophy. By doing hypertrophy for some time, all the beta cell will get exhausted, and in the end there is beta cell atrophy. पहले hypertrophy होगी, बाद में atrophy होगी. Atrophy की वजह से insulin decrease हो जाएगा और person will have frank diabetes. So these are the stages. This period is known as honeymoon period. In honeymoon period, patient have normal blood glucose level on increased insulin. Right? Have you got it? So if I'm having normal insulin, I will have normal glucose, right? But if I am having increased insulin and normal glucose, that is my normal blood glucose level maintained at increased insulin because of the resistance. This period is honeymoon. And later on, because of atrophy, insulin is decreased, so blood glucose will become high. So this is diabetes. So there are three stages: insulin and glucose. Initially, insulin is normal, so glucose is also normal. Later on increased level of insulin, glucose is normal because of hypertrophy of the pancreatic cells. Later on, the beta cell of the pancreas undergo atrophy. So insulin level will decrease, so it will increase the blood glucose level. So this stage is normal stage. This stage is honeymoon period or pre-diabetes, you can say, or honeymoon, and this stage is known as frank diabetes type 2. Have you got it? Have you got it? That I want to explain you in this diagram only. These are the three stages: 1, 2 and 3. I hope it is crystal clear to you. You can read the theory by yourself. Have you got it? So before coming to the various insulin preparations, let me summarize. Let me summarize. Okay. Type 1 diabetes and type 2 diabetes. The two type of diabetes. In type 1 diabetes, the problem is with pancreas. The beta cell of the pancreas are abnormal. They are killed by T lymphocytes, by autoimmune T lymphocytes. Here the problem with the target organ. Pancreas is normal. Target organ pe insulin receptor is non-responsive, right? So here there is a quantitative defect of the insulin. Insulin is less or absent. Here technically it is less or absent, right? Here insulin is normal or more or less, anything can happen, but it is non-functional. It is non-functional. Insulin is non-functional, so it is known as qualitative defect. So type 1 diabetes is quantitative defect of insulin. Type 2 diabetes is qualitative defect of insulin. And the organ which is defective is different. In type 1 diabetes, the defective organ is pancreas. In type 2 diabetes, the defective organ is the target organ. Have you got it? Have you got it? The target organs, liver, skeletal muscle, and adipose tissue. So that is the thing. That is the thing you should understand. You should appreciate. That is the thing. Do you have any doubt in this? So should I proceed ahead? Should I? Okay. Now you tell me what will be the treatment you will offer to type 1 or type 2. What treatment you will offer? In type 1, there is problem with pancreas beta cell. Pancreas ke beta cell are absent because they are killed by T lymphocytes. So insulin is absent. Insulin is absent in them. So treatment is only one: artificial insulin. You give artificial insulin preparation from outside to them. In type 2, the problem is not with the pancreas. The problem with the target organ, liver, skeletal muscle and adipose tissue में problem है, right? So they are non-responsive. They are non-responsive. The receptor of the insulin is non-responsive to the insulin, right? So here insulin is present. It is not the insulin is absent. It is present. It is present. It is not absent. But insulin ke receptor are non-responsive. So here treatment you will offer is oral hypoglycemic agents. These are the drugs, oral drugs, oral. These are the tablets. In the form of the tablets they come, tablets or capsules. So these are oral. The point is there, insulin is not oral. It is injectable. Insulin always come in the form of the subcutaneous injection. There is no tablet for insulin. Insulin injection में ही आता है. तो यहाँ पे ट्रीटमेंट में आपको इंसुलिन का इंजेक्शन देना है. कब? डेली. कितनी बार डेली? Whenever person have a meal. So normal person take 3 meals: breakfast, lunch, dinner. So they have to take 3 injections of insulin daily, minimum 3 injections. of insulin daily. कब से लेके कब तक? Till death. From the date of diagnosis till death, they have to take daily 3. No, it is a very tedious life. You know, type 1 diabetes are very, I'm pity on them. So there are many type 1 diabetes in the world. Daily they take 3 to 4 injections of the insulin from the date of the diagnosis. Diagnosis is usually at adolescent age because it is genetic defect now. So at 10 to 15 years of age, they are kids, they got diagnosed, and throughout their life till their death they take insulin daily. Now there are various pharmaceutical companies who are doing research on other route of insulin except injectable, because giving injection daily 3 to 4 times, you can imagine it is very tedious. Taking a tablet 3 to 4 times, it is easy, but giving injection 3 to 4 times, it is very tedious, right? So various pharmaceutical companies are working on other routes of the insulin. So some companies are making inhalers, some nasal routes, some nasal sprays, right? Some other forms of the insulin. Insulin oral is non-active. You have to give by some other route, but injection is tedious. So we can find out some, the day जिस दिन ये आ जाएगा market में, it will be the biggest, पूरा scenario change हो जाएगा, right? That is about type 1. In type 2, the treatment is a tablet, oral hypoglycemic agent that will reduce the resistance of the insulin, that will act on the insulin receptor on the target organ and reduce the resistance of the insulin. Initially, we will try with oral hypoglycemic agents. If the blood sugar level is controlled, it's good. If it is not controlled, the last resort here also treatment is artificial insulin. You will say, मैम इंसुलिन का तो रेजिस्टेंस है ना, लो लेवल इंसुलिन का रेजिस्टेंस है, थोड़ा सा नेचुरल इंसुलिन है, but when we give artificial also, the amount of insulin will become high, it will overcome the resistance. So that is the answer, right? So treatment of type 1 type 2 differs. The basic problem is that, the basic difference is that in type 1 we directly give insulin, the only treatment. In type 2, first we give oral hypoglycemic agent. If not controlled, then we give insulin. So insulin is last resort, not the first, in contrast to type 1. So your concept should be crystal clear. Okay. Before going to the artificial preparation of various kinds of insulin, let me teach you the various clinical features. The various clinical features of the diabetes, right? In a diabetic person, there are 3 P. What are the 3 Ps in a diabetic person? Polyuria, polydipsia, polyphagia. Triple P. Diabetic person presents with triple P. Polyuria, increased urination. Polydipsia, increased thirst. Polyphagia, increased hunger. And along with it, weight loss. I have already explained the reason for all these: increased urination, thirst, appetite. Along with, now these two are paradox. The person is eating more but still doing weight loss. Now it is a paradox, but it happens, right? Now what's the reason for all these? The beautiful diagram you can understand. See the beautiful diagram in front of you. Can you see this diagram? Yes, you all can see this diagram. The beautiful diagram is in front of you. In this beautiful diagram, please appreciate, this is a diagram of diabetes, right? I have already explained you this diagram. The insulin is either absent or non-functional, either qualitative defect or quantitative defect, right? So the blood glucose level cannot be shifted into the cell. So from where the glucose will go? You tell me. It cannot go into the cell. It will remain in the blood only. From blood, where it will go? It will go to the kidney for excretion. So excessive glucose present in the blood because insulin is either absent, quantitative defect, or it is non-functional. So glucose cannot be moved to the cell. So it will remain in blood only. From blood, it is going to the kidney for excretion. In the kidney, it is causing glycosuria. Glycosuria. Glucose is the osmotic molecule. It will never go alone in urine. It will drag water along with it. Osmotic का मतलब क्या होता है? वो अपने साथ पानी खींच के जाएगा. So glucose तो जाएगा, साथ में पानी भी लेके जाएगा urine में. So urine contains glucose as well as water. So patient have polyuria. More water in the urine. Patient feel urination again. So that is polyuria. Have you got it? This is known as polyuria. Give me a thumbs up. Polyuria. Now, because of polyuria, excessive water loss takes place. So the blood will become concentrated. Here the blood become excessive concentrated. All the water is already lost in the urine. So the concentrated blood will go in the brain and stimulate the thirst center. So that person feel more thirsty, polydipsia. Because of volume depletion concentration, the person feel more thirsty, polydipsia. So polyuria leads to polydipsia. It is not that thing, the polydipsia leads to polyuria. Give me a thumbs up. Person is urinating more, so drinking more water. It is not the reverse. Person drinking more water, that's why more urinating. No, it is not the thing. Have you got it? And the third thing. Now, ये तो दोनों चीजें इसकी वजह से हुई. There is more glucose in the blood, so going in the kidney for excretion. So osmotic diuresis की वजह से polyuria followed by polydipsia है. But cell is receiving less glucose, ना? Insulin is either absent or it is non-functional, qualitative, quantitative effect. So cell is having less glucose. तो लेस ग्लूकोज है तो ये सेल एटीपी कहां से बनाएगा? ऑल सेल रिक्वायर एटीपी फॉर सर्वाइवल. ये सेल एटीपी कहां से लाएगा? फ्रॉम वेयर दिस सेल विल ब्रिंग द एटीपी. This cell will form ATP either from lipid or protein. So either there is lipolysis or proteolysis that will lead to ATP formation. So normally we don't break lipid or protein for ATP formation. We obtain ATP from carbohydrates, right? Not from lipid and protein. But because of proteolysis and lipolysis, this cell is doing two things: proteolysis and lipolysis for forming ATP. So body is doing weight loss because lipid and protein both are broken down. Body is made up of lipid and protein, right? Everyone's body is made up of, the structural component is the protein and fat is the storage form, right? So weight loss होता जाएगा क्योंकि lipid भी गया, protein भी गया. और weight loss होने की वजह से for the compensation the appetite center in the brain will get stimulated and person will feel more hungry, more appetite. So person will eat more to compensate because the protein is breaking down. So polyphagia. So please see polyuria, polydipsia, polyphagia along with weight loss. So that is the thing. The same thing is shown here, which I have drawn here for you. The beautifully I have drawn, right? Now the two paradox, polyphagia and weight loss together give you the suspicion of the diabetes. Have you got it? Have you got it? Say yes or no. Say yes or no. Have you got it? Okay. We will do some questions on type 1, type 2 diabetes, and after that we will come on the artificial preparations of the insulin. The various artificial preparations of the insulin, we will come on that. Have you got it? Say yes or no. Should I start? Okay. So let me do these questions. Okay. Okay, please read it. What is the correct answer according to you? You can write your answer in the comment box. The following holds true for type 1 diabetes except type 1 except. The question is asking about except. Let me read the four options. It is associated with HLA, DR3, DR4. Yes, it is correct. I have told you in the last lecture only. It is an autoimmune disease. Yes, here the T lymphocytes become self-reactive and killing the beta cell of the pancreas. Viral infection can cause type 1 diabetes. Yes, it is also true. But twin concordance rate is not 90%, it's only 50%. 90% takes place in type 2. This I have discussed in the last lecture. Please. So correct answer here is C. Because C holds good for type 2 diabetes, not for type 1. 50% concordance rate is for type 1. Do you know what is concordance rate? Imagine twins. I'm talking about monozygotic twins, right? If now there are two situations. If one of the twin have type 1 diabetes, there is 50% chance that other twins also have type 1 diabetes. If one of the twin have type 2 diabetes, there is 90% chance that other twin have also type 2 diabetes. So this is known as the concordance rate. Concordance rate in monozygotic twins is more in type 2 diabetes as compared to type 1 diabetes. This proves that type 2 diabetes is more genetically associated as compared to type 1 diabetes. Right? So that is the summary. Correct answer here is C. Let's come on the next question. The next question is in front of you. The following are correct statement for type 2 diabetes except. Again, the question contains except. The following are the correct statement for type 2 diabetes except. So, what is not true about type 2? Okay, it is more common than IDDM, type 1 and type 2. Type 1 का other name है IDDM, Insulin Dependent Diabetes Mellitus. Type 2 का other name है NIDDF, non-insulin dependent diabetes. Here the only treatment is free insulin. Here first we will try with oral hypoglycemic drug, then come on insulin. So here it occurs as 10% diabetes only out of the total. It is 90. So read the first statement now. So type 2 is more common than type 1. Yes, the statement is correct. These patients are generally obese. Yes. Type 1 patient are generally slim. They are weight loss. And type 2 are basically obese. You have to learn, right? This differences I have discussed in the last lecture only. So this is also correct. Coming on the next question. The next question is in front of you. There is a role of insulin resistance. Yes, type 2 diabetes में insulin resistance होता है. But there is insulitis. Insulitis वहां होगा जहां autoimmunity होगी. T lymphocytes आपके islet of Langerhans पे attack करेंगे. So it takes place in type 1, not in type 2. So D is incorrect between them. Correct answer here is D. Right? Okay. This is the next question in front of you. Please read the question and tell me the correct answer. The following complication is almost exclusive in type 1. In the last lecture, I have told you. Which complication takes place only in type 1? So it is diabetic ketoacidosis, which takes place only in type 1. The rest can take in anyone. But type 1 में diabetic ketoacidosis होगा, type 2 में नहीं होगा. That I have told you very clearly. The next question, beautiful question, a difficult level question from the previous year papers of the AIMS. It is in front of you. So insulin increases glucose entry in the skeletal muscle, adipose tissue and liver by which mechanism? Insulin is implanting a door in these three target organs. Now, skeletal muscle, liver, and adipose tissue are the three target organs. So how insulin causes the glucose entry inside these three target organs? By implanting door. What is the name of the door? What is the name of the door? Is it GLUT2, GLUT4, GLUT3 ki GLUT1? I have told you very clearly. It is GLUT4. Yes, you all are right. So it is increasing the number of GLUT4 on the plasma membrane from the cell vesicle, from the cytoplasmic vesicle. So correct answer here is B. It is GLUT4. Have you got it? Have you got it? So let me move ahead. Let me move ahead. Okay, I'm leaving all these questions. So there are many questions you can do by yourself. Okay, so coming on the artificial insulin preparations. Artificial. So we have seen that artificial insulin preparations we require in type 1 diabetes. It is the only treatment. In type 2, it is the last resort. First, we will try with oral hypoglycemic drugs. Then, if it is not resolved, we will go on the insulin. So there are 4 artificial insulin preparations available in the market. So this link is expiring. Let me end this lecture and join another link. So I request you to watch the next lecture to understand about the various types of insulin preparations. So I'm ending this lecture, but you don't go anywhere. Just a second. Refresh yourself, have a cup of tea, coffee, and come back for the next lecture. Thank you very much for being with me for this lecture. I really enjoyed teaching you this lecture. And okay, on Unacademy, we have 2 types of paid subscription. One is Plus and one is Iconic. In Plus subscription, you get access to live and recorded lectures of Unacademy only from the India's top educator, right? In Iconic, along with Unacademy, we will provide you access to the prep ladder also. So now you can take Plus as well as Iconic. It's your wish, but according to me, as my suggestion, you should go with Iconic if you are thinking of taking a paid subscription, because the price difference is a little bit, but you are getting an additional advantage of prep ladder here. So, okay, I request all the learners, those who are the newcomers here, to install Unacademy Learners app from the Play Store. After installing Unacademy Learners app, select the goal as NEET PG. NEET PG is a category for all medicos. Here we do the preparation not only for NEET PG but for NICT, FMG, USMLE, other medical exams also. Right. So select the goal as NEET PG category. After entering in the category, please search my name. My name is Dr. Priyanka Sachdev. Dr. Priyanka Sachdev. Once you find my name, I suggest you to follow my profile link. Once you follow my profile link, you will get a list of my special classes. My special classes are the free classes, which I conduct not on the YouTube, but on the platform. These are free. You can attend any. There are more than 500 free recordings available of various important topics from 19 subjects. So you can watch any recording of your choice, any topic of your choice of free. These all are free, right? And these are better than YouTube because of the following reasons. You will get the notes also, right? The only thing you require a code to unlock it. The code is Sachdev10. Please use the code Sachdev10 to unlock any of my free class, SACHDEV. That is my surname, Sachdev10. Once you take the subscription, you will be eligible for all these batches you can see, which are available on the platform, NEET PG, FMG. These are the various plans you can see. For Plus, these are the plans. For Iconic, these are the plans. The best part here is that if you apply my code Sachdev10, SACHDEV Sachdev10, so you will get straightforward 20% discount instead of 10% discount if you are taking the subscription between 14th to 16th March. So this offer is valid only for 3 days. And after 3 days, if you take the same subscription, you will get only 10% discount. But if you want 20% discount, so offer is going on. Please take this opportunity and take the subscription if you are thinking of taking it in future. Thank you very much for being with me. Don't forget to attend the next lecture in which I will teach you the various insulin artificial preparations. Bye-bye. Study hard. All the best.